today. As you can see, I am on call, and so I actually tried to hold off from doing this session until I actually had a call, so that I could make sure that you all actually got to shadow me at work. And so if you hear my pager go off, excuse me. I'll just take the call and I will keep it on speakerphone so that you all will know, just kind of, you'll just get a little glimpse of the call life of an attending. And we'll just keep on hopping right back in each time. So today I am going to discuss with you all basically the road to obstetrics and gynecology. And I hope everyone can see my screen. Here are my objectives. What is an OBGYN? What is the practice setting of an OBGYN? What are the subspecialties? Why I chose obstetrics and gynecology, and then of course a view into the call life if you haven't already had it by the time we finish, go to the end. I'm going to actually show you something. That board back there allows me to see what's going on with the patients on labor and delivery, and I can't say this too loud, but there's no one there. Hallelujah. No. Okay. And actually, there's actually a patient down in women's urgent care that's on the way up too. Our hospital is set up a little bit differently. She just mentioned that I'm affiliated with the University of Mississippi Medical Center. So typically hospitals will have a triage on labor and delivery where patients that are greater than 20 weeks, they come there for an evaluation, contractions or leakage of fluid or whatever related to their obstetrical condition. And anyone less than 20 weeks, they go to just the regular emergency room. Well, at University of Mississippi Medical Center, we actually have a full women's emergency department. So we see, I don't know if you all heard me just take that call. That was a GYN patient. It wasn't an OB patient. So our GYN patients can come see us for whatever. Our OB patients can come see us for whatever. And they don't have to be greater than 20 weeks. So like I was saying, downstairs, we have someone who is on her way up, and we're going to induce her labor because she has hypertensive disease of pregnancy based on our evaluation in women's urgent care. And I'll go see her in just a little bit. Okay, so let's move on down through. So what is an OBGYN? So it's a practitioner of young ladies and women, and we'll talk about both sides. The obstetric side first. We offer prenatal counseling, care during pregnancies, care for delivery, and throughout the entire postpartum period. I know that you all have heard lots and lots about maternal mortality. It is real. It is a serious thing. And so I emphasize this postpartum care because it's just as important as the delivery and the care during pregnancies. We have now started seeing our patients. You know how people say, well, I went to my 6-week postpartum checkup. We don't do them at 6 weeks anymore. We actually do them a lot earlier, because by the time you get to the 6-week period, all the drama has already happened, and the patient has had to deal with it on her own, or she has been readmitted to the hospital. So our goal is to see patients between 2 to 3 weeks postpartum. And then for me, I try to see patients 2 times in the postpartum period. So if they're routine, I'll see them about 3 weeks, and then I'll see them again at the 6-week mark. And that'll be like the time where if they're ready to go back to work, I'll release them to go back to work. Or if they're wanting to stay longer, I'll give them a letter to go back whenever they're wanting to. But like I said, I emphasize that because many women who pass away from childbirth is typically in the postpartum period. Now there are lots that are during birth or before birth due to cardiovascular issues or thrombosis in the lungs or whatever, but the postpartum period due to hemorrhage and hypertensive disease of pregnancy and things like that is pretty significant. So that's why I say I just emphasize that, because it's very important that we follow the patients. And sometimes patients don't realize how significant the postpartum period is, or they don't realize just the changes that a pregnancy can have on the woman's body in general. And so that's where that care during deliveries is really important, just making sure they make it to all their visits and establishing a great relationship with the patient. So gynecology. So under the gynecology component, you know, we do our annual wellness visits, which would include like pap smears, of course, clinical breast exams, mammograms, age-appropriate screenings, including sexually transmitted infection testing, screening for osteoporosis, screening for intimate partner violence, depression, nutrition, exercise. So we're not just the person that's going to deal with, you know, your pregnancy. Like we deal with like a holistic you, not just a pregnant you or an annual you. Like we deal with the whole woman. Now, some practitioners also manage patients' high blood pressure and diabetes. I manage those in pregnancy, and I refer to our adult medicine team to manage during outside of pregnancy, and then I manage like the rest of what I see there, what you see there. Contraception management, of course, there are all different types of contraception. So of course, counseling about birth control. And then if there are procedures related to birth control, then a trained OBGYN can actually do those. So that would be for an intrauterine device or a Nexplanon, which is the little rod that goes in the arm. And of course, tubules. Menstrual cycle management. And of course, that is a whole beast on its own, sometimes even starting all the way in the adolescent period. But menstrual cycle management can even come to the point of a hysterectomy and other types of procedures. And then, of course, a gynecologist is a surgeon. So like if you want to use your hands and you want to work with women, gynecology is for you. All right, so practice settings, there are different practice settings. There are hospital settings. So like, for instance, if you're gonna perform a surgery or if you're gonna do your deliveries, that's gonna typically be in a hospital. Some deliveries and some people do go to birth centers, but for the most part, that's gonna be in a hospital. And then there are hospitalists. What is that? Typically, you hear about a hospitalist when it comes to internal medicine or family medicine. However, in this setting, we are talking about a person that manages whatever happens in the hospital. So they take their 12-hour shift or their 24-hour shift. Like right now, I am acting in the form of a hospitalist while I'm on call, and I will manage our women's urgent care, which is the emergency department that I just talked to you all about. I will manage the patients on our third floor, which is our antepartum, which is before delivery, and our postpartum patients after delivery. Our fifth floor, which is where our GYN patients go. And then our second floor, which is where I'm at right now, would be our labor and delivery patients. So basically, I am the hospitalist staff for everything that's happening in our hospital right now, while all the other attendings are at home with their families. There's a clinic setting. Of course, there are different types of clinic practices, private practice, federally qualified health centers, which is where I am employed. Jackson-Hinds Comprehensive Health Center is a federally qualified health center. And I'll just mention that for medical school, I had a scholarship from the National Health Service Corps, which paid for all of my medical school. And it didn't matter how much my medical school cost. I actually happened to go to one that was one of the least expensive of all the medical schools. But even if it was one of the most expensive ones, they were going to pay my entire bill, and they give you a monthly stipend. So it is a great program to look into if you all are interested in primary care. So primary care would be like your family medicine, internal medicine, pediatrics. It would also be obstetrics and gynecology, though fields like that, no subspecialties. The VA, I could actually, as a National Health Service Corps scholar, I could actually work in a government setting, a federally qualified health center, or I could work at a federal prison. Any of those would qualify me to pay back my time. When I say pay back my time, they gave me 4 years of scholarship. I give them 4 years of my time. For me, I don't feel like I'm giving them anything. They gave me everything, and now I'm giving to my patients while I'm paying back my time. This is actually exactly what I wanted to do no matter what, before I even learned about the scholarship, because I wanted to take care of the least of the people in our community. Of course, the VA hospital, there's universities, which right now, like I said, I'm affiliated with the university. This is where I have my hospital privileges, and so I take call here. And then there are multi-specialty group practices. And then there's a combination. So what I do is a combination. My day or my week looks like this. Monday, Tuesday, Wednesday, and Friday, I'm in clinic from 8 to 5. On Thursday, that is my full hospital day. So what I do those days is I do my surgery. So for instance, this past surgery, I did a hysterectomy, and then I also did some pelvic floor surgeries, which is basically plastic surgery on the vagina, if you want to say it like that. She said she wanted to have a beautiful vagina, so that's what I gave her. That, and then I had a C-section as well. I do all of most of my deliveries. Of course, some babies, they come when they get ready, and I come in the middle of the night. I come early in the morning before clinic. I stay after clinic, whatever I have to do to make sure that I take care of my patients. That's what I do. And then the ones that I'm able to schedule, if they're like, I really, really want you there, I say, okay, well, we need to schedule you on a day where I'm going to be in the hospital. So that's my combination. Moving on, subspecialties. So there are different subspecialties of obstetrics and gynecology, and there's one of obstetrics, that's maternal fetal medicine. These are practitioners that take care of women who are high risk themselves. So for instance, a patient that has lupus, high blood pressure, diabetes, any other like medical condition. For instance, if they've had multiple preterm deliveries, or if they have had a pulmonary embolus, which is a blood clot in the lungs, and they have an IVC filter, which is the filter that prevents blood clots moving from the rest of the body to the lungs. Those types of things. Sometimes general practitioners, they're like, you know what, you're a little bit more high risk than I feel comfortable with, so I'm going to send you to the high risk specialist. And they also are very, very, very good with sonography. So they do targeted anatomy sonograms, which means that they look at every single piece of the baby's body to make sure it is developing properly. The heart, the lungs, the bowel, the umbilical cord, the placenta, the kidneys, the liver. Like they look at all the fingers. They even look at the retinas in the eyes. I mean, they look at every single piece of the baby, things that you wouldn't even think to look for. That's what they look for. And they're very, very good at what they do. They also care for women who have fetal anomalies. So I didn't mention this before, but of course I said that I'm at a university, but I am actually at the only university that has obstetrics and gynecology in the state of Mississippi. So as you can imagine, we see everything here. I mean, everything. When I have seen babies without brains, I have seen babies that have hearts on the outside of their bodies. I've seen babies that have livers on the outside of their bodies. I have seen everything. I've seen conjoined twins. I've seen cleft lips. Like we see it all. We see it all. So, and that's just kind of, I'll mention that, you know, when I said that MFM people take care of women who are high risk themselves, because I have seen so much, I actually take care of all of my own hypertensive patients. I take care of all of my own diabetic patients. And honestly, I prefer to manage the diabetes in pregnancy myself over sending them to their internal medicine or family medicine doctor, because in pregnancy, glycemic control, or blood pressure or blood sugar control is a lot more tedious than outside of pregnancy. So I prefer to manage it myself. And I just send to the maternal fetal medicine doctor for the anatomy sonograms and potential fetal testing later on in the pregnancy. This is a 3-year fellowship. Subspecialties of gynecology. So there's pediatric gynecology, and of course, these are practitioners that take care of young girls in general. They take care of, you said I could just X out of that, okay. They take care of young girls who have menstrual cycle issues, or young girls who have intellectual disabilities, disabilities or physical disabilities where you want to manage their menstrual cycles in a way where you stop them. So that's where the hygiene comes from. We're not talking about, oh, you're an adolescent, you need deodorant. We're talking about stopping menstrual cycles altogether. So that's why we call it menstrual cycle hygiene from that standpoint. Uterine anomalies, so uterine didelphys, bicornuate uterus, which means that in development, the uterus doesn't come all the way together to fuse. It either comes down like that, or you have 2 uteri and 2 cervices. I have had a patient like that recently. Her pregnancy was on the right side, by the way. And then vaginal agenesis, all types of uterine anomalies. Vaginal agenesis means that the vagina just did not develop when the baby was on the inside. And sometimes those practitioners will create a vagina. And so they are surgeons. And it is a 2-year fellowship. Okay, trying to move on to my next one. Okay, another subspecialty is minimally invasive surgery. This is basically more training in laparoscopic surgeries, either with a robot or straight stick. When I say straight stick, I just mean with like the laparoscopic instruments that you're actually at the bedside by the patient and you're operating with your prolonged arms, basically your instruments. And then the robot, you're actually not by the patient. You have an actual console by the patient. You're off kind of like this, and you're looking into a system that projects what the camera is seeing on the inside by the patient, and you're operating that way. So that's the difference between robot and straight stick. And then that is a 2-year fellowship as well. And they take care of patients. They do like myomectomies, meaning removal of fibroids. They do hysterectomies. They pretty much do all of the same surgeries that general OBGYNs do. They just have extra training so that they become very, very proficient in their craft. Urogynecology is a pelvic floor specialist, and they also manage the lower urinary system. So at our hospital, we do have 1 urogynecologist. And, you know, a second ago when I mentioned the pelvic or the vaginal surgery that I did the other day, our urogynecologist actually does those procedures, but it is also the surgery of a general OBGYN. And so I said, you know, even though none of my partners here want to do those procedures, I wanted to do them, especially given the fact that I may leave here one day and where I go, the generalists are going to be doing those, and I wouldn't want to have to transfer my patient to a partner because I don't do them. So I am going to do those procedures. And basically for pelvic organ prolapse, which means dropped bladder, dropped rectum, just help to tack it all back into place and to make it to where people don't have issues with the uterus kind of falling. Yes, when I say uterus falling out of the vagina, yes, it happens. The first time I saw it, I was like, ah! But I didn't scream that loud. It was pretty shocking for me. But that happens, and that's why you have a urogynecologist, because that person is trained to fix that, and that is a 4-year fellowship. Gynecologic oncology. This is a practitioner who deals with cancers of the female reproductive tract. So ovarian cancer, uterine cancer, cervical cancer. This person operates on those patients and manages their chemotherapy. Now, there may be some gynecologic oncologists out there that don't manage their own chemotherapy. However, the one that we have here, she is the bomb.com, y'all. She is an outstanding surgeon. We call her when everything is breaking loose. We call her when, you know, we have issues, like for instance, we need to do a cesarean hysterectomy. Those are very high-risk procedures where someone has a C-section and then we turn around and do a hysterectomy after we get the baby out. Usually a lot of blood loss from those. So we typically will call our GYN oncologist to help us with those procedures. And then that is a 4-year fellowship as well. That is the end of the subspecialties. And now, why obstetrics and gynecology? Well, for me, I felt like it was a great mix of the different practice settings. I do not like doing the same thing every day, all day. I want to go to clinic and then get a call, have to leave clinic to go deliver a baby, come back. I want to be in the hospital sometimes. Sometimes the hospital is just I get to use my hands as a surgeon, and I love the gratification of surgery. Like I just love doing it. Every day is different, like I just mentioned. I love taking care of women. When I was in the seventh grade, I started. Oh, sorry. I was just looking to see who was getting on my board. When I was in the seventh grade, I actually started. I became a cheerleading coach for I think the second grade football team, and I coached cheerleading for 10 years. And throughout that time, not only was I a coach, but I was also a mentor. You know, I developed great relationships with them. And I knew I wanted to be a doctor from the time that I was like 3 years old. But you know, what does a 3-year-old know? I wanted to be a doctor, and I was like, well, you know what? I enjoy working with young girls. I enjoy working with women, and I just knew that this was what God had wanted me to do. And so that's what I did. And then, of course, when I say I love life, I love bringing new life into this world. I mean, it's a beautiful, beautiful thing to take care of a person throughout her pregnancy and then be able to be there for one of the most important moments of her life. You know, that, and then of course her marriage and her, you know, those things, those are like some really intimate and beautiful moments, and I just love sharing those with my patients. And um, the residents around here will tell you that I have a pretty special patient population, and I seem to get through to patients in a way where um, I attract patients that are sometimes very difficult to manage because of their social situations. And for me, that's the social work side of me. I don't have any training in social work, but that's just the side of me that wants to make sure that my whole patient is okay. I'm not treating the science, I'm treating the patient and her environment and her situation. So that's why I chose obstetrics and gynecology. Before we take a stroll around the hospital and go say hi to the residents, I wanted to give you all an opportunity to ask whatever questions you have. If anybody is interested in hearing my path into medicine, because I was a non-traditional student, I'm happy to share that as well. What y'all got for me? How do I stop sharing?
So you go to the bottom, and I think when you click share screen, it'll take it off.
Okay, maybe new share. Oh, no.
We have tons of questions. I can kind of go through them and moderate them for you.
Yeah, that'll be great. I
Yeah.
just don't know how to get out. It doesn't, I don't have another setting that says share screen. Like another, it just has new share.
It should
Oh,
say like
never mind.
close out.
Stop
Yeah.
sharing.
Yeah, there you go. Okay, so we have some
Ooh,
questions.
I like that. How was my MCAT experience? Oh,
Yeah.
Lord. Sorry, I'll let you go first. But yeah, I do have a MCAT experience.
Oh yeah, definitely go ahead and do that because I know a lot of people want to know the answer to that.
Well, so when I took the MCAT, so I'm only 1 year out of residency. However, I'm not very far. So, like as you can see, I'm not very far from the training period. I took the MCAT when it was like the up to 45 scale. I know it's a new scale now, but and so I don't really know how to correlate the old scale to the new one. But I'm gonna be completely honest with you all. My first time taking the MCAT, I scored an 11. That is hideous. That is, I was so embarrassed. I remember I applied to Meharry and I applied kind of late and my MCAT score wasn't back yet. And so I said, okay, well, I'm going to submit a blind application. And I had my scores go directly to them as soon as they came in. Boy, was that a mistake. That 11, that's out of 45. So that means I scored the lowest in in one section, and then the second to the lowest in another section, something like that. So that was my first experience. And then my second experience, I did worse, y'all. I scored an 8. So now at this point, I scored a 3 in one section and a 2 in 2 sections. Does that make 8? 4, 5, 6, 7. Well, I guess I scored 2 3s then. So, I mean, I had my advisor telling me to choose something different. And I was like, yo, I don't have a backup plan. Like, I need you to tell me what to do to make this MCAT work for me. Now, I'll mention this. I went to Wichita State University as an undergraduate student, and I was a student athlete. And so we had access to tutors, but I was such a great student in high school that I didn't utilize the resources that were available to me as a college student. And I regret that, but at the same time, I praise God for the journey that I've been on, because I appreciate it more, and I can share with you all. And now you can see that I'm here and doing what I'm doing after what I've gone through. But yeah, that was that. And then I went to her. This is after she told me, you know, you can't take the MCAT again until you get some help. And by the way, you need to choose something different. I was like, all right, no, I'm not going to choose anything different. I just need you to help me get some help. So she printed off, she went onto the MCAS website and she printed off all the post-baccalaureate programs in the country for me. I went through that list and she highlighted the ones that had MCAT assistance. So I ended up going to MedPrep. MedPrep is at Southern Illinois University in Carbondale, and it is a 2-year post-baccalaureate program. First year is MCAT based. The second year is basically preparing you for your first year of medical school. So you take all upper level science courses. So when I heard about that program, I applied, I didn't get in. So I said, you know what? Y'all don't have to take me, but I'm about to move there. So I moved from Kansas to Illinois to get a master's degree that I could have got in Kansas. And everybody was like, why did you do that? Like, why are you moving from here to do something that you can do here? And I was like, because I need to be in their faces. So basically, while I was there for my 2-year Master of Public Health program, I basically went and met with the director of MedPrep every single semester. And I told him, and before I left, I said, Lord, I need a 4.0. Like, I can't have anything less than a 4.0 with this master's degree program. And that's what I did. Got a 4.0, but I went to him every semester. I said, look, this is what I did this semester. What you want me to do next? He was like, I want you to take some upper level science courses with your master's degree program. Well, graduate work is a little different than undergraduate work. That's number one. And number two, upper level science work is a little different than lower level science work. I took 18 credit hours coursework in one semester. Do y'all know that was crazy? I didn't care. I knew that I had a goal in mind, and I had basically a transformed mind about how my studying was going to be, and that's what I was going to do. So I took it. I got a 4.0. I went back to him again. I said, I just passed both of those classes with A's. What you want me to do next? He was like, okay, I need you to do this next. I said, okay. I went back to him again. What you want me to do next? He's like, this is what he said, Jaleen, you've done everything I asked you to do, just graduate. That's all I need you to do. Just graduate. So I graduated. I got into MedPrep, and it was like an outstanding program. Of course, if anybody has questions about that, please inbox me on Instagram or wherever, and I can assist you all with, contacting them or looking at the program, sending you the link for the program, whatever. But anyways, I was able to do I think I improved by, I don't know, I can't remember how many points I improved by. I just know that when I met with the admissions coordinator at Indiana University, he was like, oh my gosh, did you really improve by this many points? I was like, yeah, I mean, and he was like, that is significant. That's just because I was so bad before and because I had such great help in the MedPrep program at the current time. And so that is my MedPrep or my MCAT experience. It was a journey, but I made it through.
That is so inspiring. wow. All the comments are just so in shock and in awe of how awesome you are for being so resilient.
See any other questions in there? I see all the, yeah, thank y'all.
Right now, it's all just praise.
I love y'all, for real. And y'all, I mean, I'm telling you, the path that I went on, I mean, I finally learned how to use the resources that are available to me. I see y'all in National Health Service Corps Scholarship. And as a result, now anytime someone reaches out to me, I mean, I have random people reach out to me on Instagram, Facebook, and I respond with like all my might. I may say, hey, give me a couple days and I'll get back to you, and I'll send like a whole like 15 paragraphs, because I want people to succeed. Like, we are here to reach down and pull everyone else up. Like, we are not lions and gazelles where, you know, you're at the top and you kick and knock people down the bucket or down into the hole. Like, once you make it, reach back and help somebody else make it, because we all got to do well. We all have to do it.
Absolutely.
Someone mentioned the National Health Service Corps Scholarship.
Yeah.
That is through the basically it's a federal government scholarship. And if you just Google National Health Service Corps Scholarship, CORP scholarship, you will see that there are different types of scholarships. I'll just mention that the one that I had was where I received funding during medical school, but there's also one, say for instance, you go into medical school, you're not really sure if you want to go into primary care, because let me tell you, if you take that scholarship and you do not go into primary care, you are going to have to pay back all of the money with interest in a very short period of time. So that is like not what you all want. Like, I mean, the scholarship is a significant, I mean, I ended up getting like a $10,000 scholarship right before I found out that I had it. And I contacted them. I said, hey, I just got this $10,000 scholarship. What do I do? And they said, you can either keep it and we'll pay the difference, or you can give it back. And I was like, well, in that regard, let me give it to a classmate. So I gave back the $10,000 scholarship and took the scholarship that I knew would be coming to me. So like, that's how significant it is. They were like, I don't care, whatever you want to do. Like, they weren't trying to save money. And so then that's that part. Then there's one where when you come into residency, if like at that point when you realize, okay, yes, I am going to be a primary care specialist at this point. So you can get it during residency, which means that they will start to pay back your loans while you're in residency. And then when you come out of residency, then you pay back your time. So it is 1 year for 1 year with a minimum of 2 years that you pay back. So if you only receive 1 year of assistance from them, they are going to require you to do 2 years. But otherwise, like for me, I received a 4-year scholarship, so I am paying back 4 years. But like I said, it's not payback. Like, this is where I want it to be anyway. Then there is a service scholarship. So while I am working, and say I didn't know anything about the scholarship before, but then I go and practice at a federally qualified health center, and now I have all these student loans, then you can qualify at that point, and they can pay back your student loans at that point. And I think they do like $35,000 for the first 2 years, and then after that, I think they like go like $10,000 or $15,000 a year, and they just give you kind of a lump sum and let you just drop it on your loans. And so it's actually a really, really good program if you know that you're going to be in primary care and you know you're going to be in an underserved setting. Oh, I'll also mention that a lot of states also have it. And like in the state of Mississippi, I'm actually on the board for our rural scholars program. And so our medical students can go into rural areas of Mississippi and practice, and we can give them a scholarship as well. What other questions do you all have? Do you see any others?
Yeah, so we had some talk or asking about the difference between fetal maternal medicine and neonatology. If you
Okay.
could go off that.
So yes, that's actually a very, very good question. You know how people say, I'm a baby doctor? Baby doctors are really the pediatricians. People just say we're baby doctors. We're actually fetal doctors. So maternal fetal medicine takes care of the mom and the baby on the inside. And typically in that first like 30 to 60 seconds after delivery, like while I'm holding the baby, drying the baby off, blah, blah, blah. And then I'm like, bye-bye, baby, you can go on to your people. So the neonatologist is the one that takes care of the newborn baby after the baby is born. So what we do is, for instance, if I deliver someone who is preterm right now, y'all can see there are 2 patients on the board there. One of them has twins. She's preterm, and she's actually being monitored for twin transfusion syndrome. And so that's why she's on the monitor. So for her, if we were to deliver her, her babies would have to go to the neonatal intensive care unit. So the neonatologist is the one that takes care of the newborn baby in the ICU. I also had a 30-week baby. I had preeclampsia. Well, I was sick, y'all. I was sick. And it was crazy that I was sick in my own hospital with stuff that I deal with every single day. But that's the story for another day. If y'all see my my Instagram, I actually posted about that earlier this week. But anyways, that is where that's the difference between the two. The newborn baby, the baby on the inside. You're a twin and your mom had you at 27 weeks because of preeclampsia. Yep, you stayed in the hospital for a while too. Praise God you're here and well.
We had some questions about like work-life balance and, you know, having a family, and I know you have some kids, so you can touch on that a little bit as an OBGYN.
Absolutely. So because I work at a community health center and I'm affiliated with the university, the cool thing about my situation is that I don't necessarily have to take call. I take call for all of my own patients, but if I am busy or I don't feel like it or I'm tired, and I'm not saying that in a mean way, I'm just like, you know, you can get very, very fatigued if you try to be at every single delivery. You have a backup system here in the hospital. For instance, I'm here right now, so all of my partners, if they're at home with their families, they don't have to come in because they can trust in me to take care of their patients. And so having hospital privileges at a place where you are covered by a residency program and you're covered by other staff in the hospital is very helpful. You could say, like, for instance, when COVID got really significant initially, like back in March, I told myself, I said, you know, the risk is already high for me. And at the time we weren't checking all of our patients for COVID. We weren't testing everybody at the time. And so I didn't come in for any deliveries if it wasn't during business hours. I said, and I told my patients that, I said, hey, I'm really sorry if you happen to deliver while I am not already at work during business hours, and if I've already made it home, because of the coronavirus, I'm not going to be able to come in because I'm trying to keep my family safe. And so you can establish that type of relationship with patients and let them know, and they typically understand. But work-life balance, I will tell you from an OBGYN standpoint, it is difficult at times because you develop this great relationship with patients and you really want to be there for them. And sometimes you have to make the decision to choose your family first, because really what it is, family first. So when you start to develop your relationships, your intimate relationships, and you start having children, like, and you know that you're going to be a physician, I think that it's very important to establish basically the the relationship in a way where you know, where your partner is going to know that you may be on call some days, you may have to go in, you may work late, like you have to just establish that relationship. And honestly, if there is a person who you're interested in but has a problem with you being gone and working 50, 60, 70, 80, 90 hours a week, especially during residency, yeah, they say we're only supposed to work 80, but who does that? Maybe emergency medicine residents. I think they, you know, they meet their quota, but everybody else that I know of, they work over the time. We just don't tell everybody we work over the time. But what I'm getting at is, if your partner can't handle you being gone, that's probably not the partner for you. You have to develop a relationship with someone who is going to understand your life as a physician. Another work-life balance type of thing, really more so on a relationship type of thing, if your partner is not also a physician, your partner has to be okay with you making more money than them. I just had to mention that. I know nobody asked me that, but my husband, he's a high earner, but he's okay with the fact that I make more than twice as much as him, because we're a team. And we know that from the beginning, like I met him when I was going into graduate school. We knew that I was going to go to medical school, and we knew that at some point I was going to be the higher earner. He was the higher earner all the way up until I became an attending, and that's when, you know, it changed over. So the person has to be secure. And so anyways, I just say family first, and, you know, find times to, like, sometimes like this coming weekend, next weekend, I told myself I'm turning off my phone. I'm not going to go in for any patients over the weekend. It's the holiday. And I'm just going to do family time. And sometimes you have to do that, and that becomes a part of your work-life balance. There are times that you're going to be very stressed. I mean, get you a membership at Massage Envy or wherever, so you can go and get your monthly massages. Like, your self-care cannot take a back seat. But figure out things that you love and try to make sure that you do them. Find your set group of friends, because let me talk to y'all about some friends. I'm sorry, I'm going off. But let me talk to y'all about some friends. You will find out who your real friends are after you become successful. Those ones that are still there are the ones that are your true friends. The ones that are still friends with you on your social media to watch what you're doing and talk to someone else about you, those are not your friends, and you will soon find out. So just be very, very careful who you share your intimate time with. And I'm not talking about boyfriend, girlfriend type of stuff, just your intimate time, like your space with, like your head space. Those ones that are going to, like, push you, motivate you. They're not going to tell you, like, hey, go find something else to do. Like, those people that are going to be there for you and to push you, even at your lowest, getting an 8 on your MCAT or a 447. I think I saw somebody, like, moved it over. They did the correlation, 447 or something. Those are the ones that are going to be with you in the end. All right, I'm sorry. I'm going to let y'all ask another question, because I'll keep on going.
No, everyone is obsessed. Like, honestly, it's so true. To go into more or less personal questions. Everyone loves you. I guess there's a lot of questions before the praise came about just discussing pulmonary embolisms and the dangers or risk factors to ectopic pregnancies.
Okay, so pulmonary embolus. Let me go there first. So first, the pulmonary embolus is a blood clot in the lungs that can lead to death. I have to say that it can lead to death. The highest time for coagulopathy, I'll say coagulopathy because you can get a DVT, which is a blood clot in the legs, like the veins of the legs. You can get them in your arms, you can get them wherever, and they can break off and then they go to the lungs, is in the first couple of weeks postpartum. That is where the highest risk is. So for patients that are obese, we actually put them on anticoagulation if they have had a cesarean section, because that even increases the risk even more. So we place them on a medication called Lovenox. It's an injection. It's a blood thinner that helps to reduce the risk of blood clots in the postpartum period. But pregnancy in general is also a risk factor. And so we just basically have to, do people who suffer from migraine headaches have a higher risk for pulmonary embolism in the postpartum period? I'll mention the blood clots related to migraine headaches in just a moment. I don't believe that, no. But yeah, pulmonary embolism, that's the highest risk, right in that postpartum period, but the whole pregnancy, just because the hormone levels are a lot higher. There are some patients that we do not place on combination contraception, meaning estrogen and progesterone, which are the two girly hormones. I call it girly parts. The two girly part hormones. And we like to put them on just progesterone only because the estrogen is typically what increases the risk for venous thromboembolism. Now, as it relates to migraines, people that have migraine headaches with an aura. So an aura is a neurological symptom that lets the patient know that they are getting ready to develop a migraine headache. Those are the people that we do not like to place on contraception that has estrogen in them, but it does not increase the risk for postpartum PEs though. Oh, and the reason why we don't like to place them on estrogen type hormones is because you have an increased risk for like basically blood clots, strokes, because it's neurological symptoms. There's spasms in the vessels in the brain, and then of course you have that spasm there, and you can get a blood clot there when the vessel is thinner or like more narrow. Somebody mentioned, how does gestational diabetes occur? So the placenta releases a hormone that basically makes the insulin that your body develops or makes on its own, it makes your body less resistant or more resistant to it. So that's why it's called diabetes in pregnancy, because your body, oh, and by the way, I had that too. Y'all, I had everything. They say healthcare providers be going off, and I sure went off like I had everybody scared. I had gestational diabetes. Baby doing something on the monitor over there. I had gestational diabetes, I had gestational hypertension, and then it led to preeclampsia. But anyways, yeah, it causes the mom's insulin not to work as well. And so as a result, we place the mom on a diabetic diet, and we also ask them to exercise if they can. We test for that between, starting at 24 weeks, you can do it all the way. It's really between 24 and 26 weeks, but sometimes we do it up to like 28. I'll do it all the way into the 30s. Like if you miss all your visits and I see you at 34 weeks, I'm like, you getting a 1 hour sugar today. You're gonna do it because I need to know. I need to know what's going on with your placenta. So anyways, some people say, well, we're gonna get an A1C, a hemoglobin A1C. Well, that is not a good measure in pregnancy. A1Cs tell you how well the blood sugar is controlled over a 3-month period, but like it's not that great of a measure in pregnancy, given the fact that you have a lot more fluid in your system, and so it is it's like basically putting too much water in the Kool-Aid. It's diluted, so sometimes it can be a little lower than before. All right. That's gestational diabetes. What y'all got for me? What's next?
Oh my gosh. Everyone loves this.
DO versus MD.
You can get into it if you want.
So honestly, I'm gonna be like, y'all, I am being so transparent here. I'm gonna be completely honest with y'all. Y'all ask me whatever, and I'm gonna tell y'all the truth. So I initially wanted to go down the DO route because I really liked the holistic care that DO offers. The reason I did not go down that route, as you can see, I am a female and I'm also African American. I did not want any other issues as far as bias holding me back, because at the time there was a stigma related to DO. DO physicians are just as competent, I mean, there is no difference. Like, they actually have to take, and you're right, there still is a stigma. But when we have residents here that are, DOs and MDs, and they all train well. Like, you just got to train the resident. They're people. But I'll tell you, the DO residents can go in here and give me a chiropractic adjustment while we at work. I do like that. Anyways, no, that is the reason why I did not choose it. It may not be the right reason, but that is my reason that I didn't do it. But if someone tells me they're going down the DO route, I say, you go for it. But there are different tests that you have to take. And if you're trying to get into an MD residency program, you just got more steps you got to take. The reason why the stigma was there is because they used to say that it was easier to get into a DO school than an MD school. Well, while that might be true, you're still... Sorry, hold on one second, y'all. They're texting me. So I buy them lunch or dinner, so I think they're ready to eat. I usually would have made their food by now. Hey, just tell me how much the food is, and I'll give y'all the money. Okay. All right, bye. No, I don't. I'm gonna go get some Subway or something. Bye. Okay. They're like, it's funny because like when you're not for sure if the attending is gonna pay, they put you in a text message group. And they're all like, hey, what do y'all want to eat? And I'm like, y'all know I'm gonna pay. Stop, don't do me like that. Y'all know I'm gonna pay. Stop playing. Anyways, where was we? What's next? What's y'all next question?
Everyone wants to go move over there and just hang out with you all the time. Those are the questions. But yeah, guys, if you have any questions and not...
I feel like, how do you, you know what? Somebody mentioned abortions. I couldn't read the whole question because the next one popped up so quickly. Let me just tell y'all about a case that I had since we're shadowing. I won't tell every single detail, but at our hospital, because I'll let y'all see the hospital. Because I am at a state institution, we cannot legally perform abortions here at our hospital, but there is a clinic that's not too far from our hospital. I think it's called like Healthcare for Women, Jackson Healthcare for Women or something like that. But they can perform abortions there up to a certain gestational age. The reason why we can perform an abortion is under the circumstance that there's a patient that potentially can pass away if she proceeds with her delivery, with her pregnancy. So let me give y'all a couple of cases. I had a patient when I was a third year resident that had a significant lung condition. And even at 6 weeks pregnant, she was already requiring more oxygen. So she went to the pulmonologist and they had a candid discussion with her and they told her, look, you can potentially die and you have this % of chance of death if you move forward with your pregnancy. Well, she was advanced maternal age, which is basically greater than the age of 35. Who put that age anyway? I'm older than 35 and I don't feel old. Anyway, older than the age of 35. I think she was like in her 40s maybe. And she was obese and she had pulmonary fibrosis, basically a significant lung disease. She had never been pregnant before. She had just gotten out of prison for an extended period of time. So she got out, boom, got pregnant. And that's why I think that they need to be giving some birth control to these ladies in prison. Let me tell y'all something. I am going to be advocating for that through the American Medical Association. And hopefully one of these days I will be able to, Josh is really worried about the salsa situation. Oh my gosh, y'all, these residents, they're getting Mexican food. She had all of these conditions. She was told that she might die. She wanted her pregnancy so badly that she continued. And, you know, we supported her. We said, we're going to support you no matter what. Well, I initially met her when she was like 13 weeks and she was already severely decompensated. So we admitted her. She was actually in the ICU for a while because she required a significant amount of oxygen, where she had to be on high flow nasal cannula. So normally you might see somebody walking around using like 2 liters, 1 liter, 3 liters, 4 liters, whatever. She was on 50 liters per minute of oxygen. That is significant. So that was her last time seeing the outside world. She did die. Right before when she got so decompensated that we were actually about to intubate her, and they knew that once they intubated her, that her lungs were going to give up. Because it was like, we're working so hard right now that as soon as you give me a little rest, I'm going to plop out. It's like you going and going and going and going and going, and you don't realize how tired you are. But as soon as you hit the bed, you're like, dang, I don't even remember. And the next morning you wake up frantic because you're like, you think you late for school and it's Sunday. But that's exactly what her lungs did. It's kind of how our bodies do when we're really, really tired. So she was only 19 weeks. We asked her right before they intubated her, we said, what do you want us to do? Would you like us to terminate your pregnancy, or do you want to stay pregnant? What do you want us to do? Because they're getting ready to put in a breathing tube. She said, go ahead and terminate. So we terminated her pregnancy by just giving her some medicine while she was in the ICU. She was intubated, and that was the end. She was compassionately extubated, and she passed away not too long after that. So under those circumstances, we have to go through the ethics and the legal team at our hospital to perform those type of abortions. I also did one recently. It was at, this patient was 16 weeks and she had preeclampsia. And our governing body tells us if we see preeclampsia prior to viability that we should terminate, because we're at this point trying to save the life of the mom. So under that circumstance, I had to terminate her pregnancy, and she was my patient. It was very, very sad. Very, very sad.
Yeah, there are a few questions just asking about how like you deal with the loss of, a patient, or in that situation, how you can still keep going, dealing with that, because that's obviously very emotional.
It is. It's very difficult, I think, and that goes back to your friends. You have to have friends that you can talk to. I am lucky to have several OBGYN good friends that I went to medical school with. One of them is one that I actually went to graduate school, med prep with, and I grew up all the way down from like Sunshine Band, basically church together. And she is an OBGYN as well. So when I have a difficult situation, I say, I need to call somebody who understands. Because like I can talk to my husband and tell him like, man, I feel so bad. I had to terminate the pregnancy. And he's very, very supportive. Like, I love that about him. But like when it comes to the procedure that I did to terminate her pregnancy, that's what hurt me the most. Like, I didn't do a medical abortion. I did a surgical abortion. And it's actually pretty brutal, those procedures. They're very brutal when it's actually a formed baby. And so it was really sad for me, y'all. I mean, it was really sad. But when you have a support system with your friends, you call them and you just tell them like, man, I had to do a D&E. That's what it's called, a dilation and evacuation. It's not a D&C where it's like a baby that's like small, it's not developed, and you just scrape. A D&E is you actually have to evacuate the baby's home. So you pull the baby out. And so you deal with it by just, and I hear some people, some psychiatrists, they say every psychiatrist has their own psychiatrist. Like, we're not saying that, you have a mental health disorder or anything. It's just saying that it's always good to have somebody to talk to. So even if you have a professional person to talk to, it's always good to also have like, your outlet at home. That's why I talked about getting your memberships to the gym and Massage Envy or whatever, just making sure that you can have a way where you can say, okay, I've left work and now I'm home and I'm gonna get into my home headspace. For me, I'm pretty good at compartmentalizing things, but I do know that there are some people that are not very good at that. And so you just have to, try to figure out the type of personality that you have and figure out ways that will help you under your type of personality.
Yeah, that's so true.
And the shoulder dystocia. Yes.
Also the C-section question that's come up.
Resident broke a baby's arm. I'm just being honest. Because the baby got stuck with the dystocia. And we say bones heal, brains don't. If that baby had stayed in any longer, could have had cerebral palsy or, some other neurological deficit that would not have allowed the baby either to live or would not have allowed the baby to just, function normally. And so I did break the baby's humerus, and the baby delivered successfully, and baby's doing great now. But you do have injuries from that sometimes. Not all the time. Most of my shoulder dystocias, I'm able to do all the maneuvers that we learn in residency, and then, everything is good. What else? Somebody said something about a C-section a second ago. How often do I see breast cancer? I was diagnosed with my first breast cancer as an attending a couple of months ago. That was really, really sad. But that's why you see these patients through everything. It's not very common that you'll see a breast cancer, but you'll find them. I have seen multiple breast masses that thankfully they were non-malignant that were watching them, but I've only diagnosed one breast cancer so far. Yep, I'll give y'all a tour of the hospital.
Let's do one last.
If I wasn't doing this, what would I normally be doing? I'd be at the crib chilling. I would be with, let me see, what time is it? It's 8:28. So Zoe would be asleep. She's 19 months old. She's my sweet baby. She would probably be sleeping, and I would just be kind of hanging out around the house, watching movies with my husband.
That's perfect. Okay, let's do maybe one more question that was relevant, the C-section question. I think it was something about how do you feel about some patients electing to choose C-sections and kind of planning their birth? Because I've definitely heard a lot of OBGYNs say that it's not your responsibility.
Yeah, we don't recommend a C-section just because the risk is higher. So when you compare a vaginal versus a cesarean birth, you have a longer hospital stay, your pain control is different, of course. It's a lot more pain related to it, and your recovery time is longer. And there are risks related to surgeries. So what do I tell patients when I am sending them for surgery? I tell them there's a risk of excessive blood loss, infection, damage to surrounding structures like the bowel, the bladder, nerves, arteries, veins, and muscles. And then also tell them there's also a risk of blood clots, heart attack, stroke, and death. I say that for all of my surgeries. So our goal is to, of course, prevent all of that. So we prefer people to have a vaginal delivery. However, there are some circumstances where once you counsel the patient, this is where shared decision making comes in place. You can't tell somebody what they should do, how they should do it. However, you can counsel them, and then you can allow them to make the final decision. And I'm going to support my patients no matter what. If they let me back that up. I'm gonna tell y'all something after that. If they say, if they are a good candidate for a C-section or a good candidate for a vaginal delivery, and of course, after a C-section, I'm gonna support them. There are some circumstances where I do not support a vaginal delivery. I have had patients where the baby was not looking very reassuring on the monitor, and I was concerned for the life of the baby. And under those circumstances, I do not support a vaginal delivery. I support a C-section. And so you just have to use your medical knowledge and your evaluation of the heart rate tracing. I am gonna put you all on my cell phone so that we can take a walk around this hospital. I appreciate y'all, all the love. Y'all feel free to reach out to me on social media. I'm Jaleen Sims 01 on Instagram. Sorry.
Okay, you are still muted.
Oh, there we go.
There you go.
There we go. This is the physician lounge. And there's a little bed back there. And this is our big monitor where we can see all the babies up there. As you can see, there's only one baby on the monitor right now. And we're going to go to the resident lounge so y'all can say hi to them. Oh, these are the resident call rooms. Just kind of through this area. And then a little resident library. Oh, this is where they do their simulation. So this is like a laparoscopic setup. And then there's a TV screen there that they can use and just kind of do some laparoscopic skills. And same for this right here. You can place operative ports for a straight stick through these here and do your procedure up there while watching it on the monitor. So that's pretty cool. We also have a practice robot too. Now we are out on labor and delivery. Hey y'all. I have some students shadowing me and they wanted to meet y'all. We're socially distant shadowing.
Excellent. Hello.
Hey.
Guys, you guys can
They're
unmute
here
and say
to
hi if you
hang
want.
Oh, it's like 200 and some students on here. So they just say hi to y'all. Anyways, hey, what's my bill? How much is it? Okay, well just let me know. Oh, so I didn't get to stop and get any cash on the way here, so maybe we could pay over the phone. I can give y'all my card.
Venmo or something. Oh yeah, or over the phone. That's perfect.
Or PayPal.
Downstairs doing it.
Okay, sounds good. This is labor and delivery. I ain't gonna grab people. Hey, ooh, somebody had a party. Whose party?
They had a wedding shower
today. That's awesome. Cool. Hey y'all. I don't want to see y'all tonight. Just saying. Those were the nurses. I told them I don't want to see them tonight because if I see them, that means I'm going to the OR or something. Hey, what's up, y'all? I don't want to see y'all tonight. Right? They said sound good. This is the operating room. So on labor and delivery, we have our own operating rooms. These are our GYN rooms here. So this is the room that I operate in for my GYN cases. So we have 3 GYN ORs and then we have 2 OB ORs. This, as y'all can see, is for a STAT, meaning an emergency COVID C-section. So it's already set up with the incubators and everything. So we do not use that OR unless it is a COVID C-section. And yes, we have them. This, as you can see, this is where we do our robotic cases. Here is the thing that does all the actual surgery, and this is where the surgeon sits. And this is where we do most of our C-sections over here. Of course, you don't see data in here. So that's that. Now I'm gonna take y'all down to our women's urgent care. And I'm happy to answer any questions that y'all may have while we're still running around this place trying to get my steps in. So we can go through the other.
Just saying how exciting this is, and they'd be bouncing off the walls if they were there in person. I don't know. Is it frozen for everyone? Give it a second.
Sorry, I think my phone can go, so I didn't get to hear what you said.
No, it's okay. Basically, we were just saying that everyone just loves seeing everything. They'd be bouncing off the walls if they were shadowing in person right now.
Cool. So these are our patient rooms in our own women's urgent care. This is our COVID materials, like our equipment. We got our own little sonograms there. Hi. I don't want to see y'all tonight either. What's up? So this is our resident doctor area that we just hang out at. So there's a bunch of students on here. They shadowing me today. So
Hey y'all.
So anyway, she is one of our 3rd year residents. So we have 4 residents on call, and there's they're saying hi.
Hey y'all.
There's a 1st year and a 3rd year that runs women's urgent care and does all the consults, and then there's a 2nd year and a 4th year who y'all just met, and they are on labor and delivery. So they take care of all of the patients up there. And the chief is kind of like over everything. So like if Danielle here has a question or issue or whatever, she can go to the chief resident and get help. So this is that area. And as y'all can see behind me, in front of me, that's the little monitor that shows like whatever patients are here in women's urgent care, that so we can watch the babies while we're sitting here and charting and things like that. So how much is the food?
I don't know because I can't call them because they're not answering. So I think I'm just gonna go there and order.
Okay. So I just come upstairs and get my card then, because I didn't bring any cash today. I know I usually just get cash.
Do you want me to just get it and then you Venmo me or something?
Well, I don't have Venmo. I got PayPal that I can use.
Okay.
You got PayPal? Look at you, girl. Everybody be like, you got Cash App? And I'm like, I got Cash App, but it's not connected to the right account. Okay, that sounds good. Huh? You're welcome. See y'all later. Y'all, they just be spending my money. Here's like the little registration area up front. And here are a little bit different type of rooms. These are just some quick exam rooms where, where the patient doesn't have to like get on the monitor or something like that. So anyways, this is a really nice facility. We got some microscopes in here where we can do wet preps and things like that. Treat somebody trichomonas on the spot. And there's just like a little lounge. So that's pretty much, that's what we got, y'all. The 5th floor and the 3rd floor look just like the 2nd floor. So we don't have to go there. We don't have to go there. So any other questions?
The most popular question right now is if we could have you back on socially distant shadowers again in the future.
Yeah, sure. Which I want
Everyone
to talk
loves
about.
you. Yeah, if you guys want to like let us know some questions that you want answered, some things that you'd like to hear about, we can gather those up and then email you.
Yeah, that sounds fine. And I'm happy to answer social questions too. I know I kind of went into it today a little bit, just about friends and, relationships and stuff like that, because those are types of things that people don't necessarily think about. And they're really important to be like having them in the forefront of your mind, even though school is really the most important thing. You just got to think about, those other social things too.
Yeah, absolutely. Yeah, so you guys keep asking those questions and I'll record all of them for Dr. Sims, and then I'll just compile them all together for you, and then we can work it out, and hopefully, in the next year or in the next semester for us, I guess. Because they love you. There's so many comments saying that you are their favorite virtual shadowing session ever.
Oh, that's so nice.
Yeah.
This has been great. I've definitely had a good time talking to y'all.
Yes, we appreciate it so much. Thank you so much for your time.
You're welcome.
Yeah, all of it's just praise. I'll send it all to you. But yeah, thank you so much. I don't want to keep you too long. You got residents to feed.
Yeah, no problem. No, they don't need me. They want my money.
And everyone's saying thank you, like good kids.
Yeah, Yep. And feel free to hit me up on social.
I'm gonna put her IG in here as well for you guys. All right. I gave everyone your IG, so you guys definitely follow her.
Take out the Y. Yep. Hold on. Take out the Y. Just
Oh, yeah,
J-A-L-E.
you're right.
Yep.
Why did I do that?
It's okay. Yep. JALEEN-SIMS01.
You're one, yeah.
There
we go.
There is a fake one out there. Make sure it's the one that actually has something in the part that like talks about me. The other one doesn't have anything on it. I forgot to mention to you all, and this might be something that some of you are interested in, but here at the university, I am the Associate Program Director for Wellness, Diversity, Equity, and Inclusion. So what does that mean? Our goal is to make a more diverse program and also to make sure that implicit bias and things like that, you know, to tackle maternal mortality, especially among African-American women, is, you know, at the forefront of our minds. And so that's another thing that, you know, was kind of like big in the media right now. So I just thought I'd mention that to you all.
Yeah,
Yes,
awesome.
that's correct.
Yes. My computer's being so slow. I'm sorry, guys. Yeah, okay, perfect. Wow, there's so many comments. That's why it's going so slow. Everyone's just obsessed with you.
That's so nice. Look, I'm ready to move to Mississippi. You're welcome. You all are so welcome.
Yes, thank you so much. We appreciate it. And yeah, we'll definitely, Lana and I will be in contact with you hopefully very soon, and hopefully see you back in 2021. So close, so far.
Sounds good. We'll definitely get something together. Y'all have a good one.
Thank you so much. We appreciate it.
Yeah.
And then